Hi, my name is Liv Swanger. I am a pharmacist with internal medicine, and I am calling in regarding to Miss Helen Thomas, a mutual patient. She was born on 9/28/1979, which makes her 42 years old. She's a Black female. She speaks English. She has good insurance, so that won't be an issue when discussing her therapies. Her initial chief complaint was that she has been feeling nauseous and tired, irritable. She's had breast soreness. She did take a pregnancy test, which rendered positive, and she does have an established appointment with her OB in 4 weeks. However, she's in today wanting to make sure that the medications she is on will not harm her baby, how to optimize those, and just general care until she can get connected with her OB. She did stop her birth control, thinking that she didn't need it. She is 42 years old, and whenever she stopped her birth control, this did open the window for her to get pregnant while she is she has not gone into menopause yet. And she is kind of worried about her job being a massage therapist, that she is unable to make her job demands, which then would compromise her financially, including that insurance. And so I think with this appointment, we just want to make sure that all of our bases are covered and that she feels supported in this pregnancy and in her social life. Some goals of my overall recommendations are that we want to make sure that her depression is managed throughout her pregnancy, that she's metabolically stable given her hypothyroidism, which we will discuss later, and that her medications are optimized given her situation. Being pregnant, there are several medications that can potentially be teratogenic or be compromising in pregnancy, and we want to discuss those today so we can optimize her care. And obviously when we want to prevent fetal harm. So she does not have any known drug allergies, which is good. Her past medical history that is pertinent to this case does include depression for 15 years. She has had 2 previous depression episodes. One was including a postpartum episode with her last pregnancy, with her last son. She currently has 2 children. And so I think we need to pay extra attention to that. She also has hypothyroidism, which is requiring thyroid hormone replacement, and she does suffer from migraines. She does exercise weekly, several times a week. She was a previous smoker. However, she quit over 20 years ago. That was more of a college thing, and she has since quit. She does, however, occasionally drink alcohol on weekends. Her vital signs look really good. She's stable, generally healthy. She's not obese. She is kind of in that overweight category, looking at BMI, but her blood pressure is good, 130/80. I would expect a slight increase in that with pregnancy. Pulse is 76, respiratory rate is 17, and temperature is 36.3, which are all fairly within normal limits. However, upon reviewing her labs, her hematocrit and hemoglobin were slightly low. Hemoglobin was 13, hematocrit was 40, which is a little bit lower than we want to see it. That can compromise her oxygen perfusion, and we want to make sure that's optimized, especially during pregnancy. She does have a negative COVID-19 test, which is good. And then she did have a positive HCG test via lab, which indicated pregnancy, and she is in her first trimester. She's looking, I think, to be 4 to 6 weeks in. And her urinalysis is normal, so we don't have to worry about any bacterial infections in the urinary region. And so her current medication list is ondansetron, which she was prescribed by an outpatient, or I think it was an urgent care clinic, after her son got sick, and she associated the nausea with that, for which she was prescribed ondansetron. She's taking paroxetine 20 mg, 1 tablet by mouth once daily, levothyroxine 125 micrograms, 1 tablet by mouth once daily, and topiramate 50 mg, 1 tablet by mouth once daily. And I'd like to go through each one of these and talk about these medications and what I'd like to do with them and what I feel are better options. So for her ondansetron, there is some mixed evidence on ondansetron. However, she did express that she wanted something that was over the counter, which is understandable. She is welcome to finish that ondansetron if she likes. If she wants to toss it, that's totally fine too. If she does want to continue it, I would suggest the oral dissolving tablet, which would be easier for her to manage her nausea. However, for non-pharmacological, to help manage her nausea and vomiting, I would just avoid trigger foods. That could be spicy foods, prevent eating large meals. So she might want to have smaller meals, break them up throughout the day. Ginger products potentially may help, and additionally peppermint, such as peppermint tea, could help like ease her stomach. So that's something to look into to consider. If she wanted something over the counter that was pharmacological, she could go with doxylamine, which does have evidence of being safe in pregnancy. And I would suggest that at 25 milligrams as needed once daily. Moving on to her migraines. So she's currently taking topiramate. This has a history of being teratogenic. And with that being said, I would stop this immediately. I would discontinue the topiramate and look at other options to help manage her migraine. This could include acetaminophen, 325 to 500 mg, every 4 to 6 hours with a max dose of 4 grams. With that being said, I would not maximize that acetaminophen if she can prevent that. Another option that we could do, depending on her situation, how bad the migraines are, how much they're compromising her quality of life, etc., would be Sumatriptan. This is different from topiramate in that it is a PRN use, not a once daily topiramate. As topiramate is a once daily prophylactic. So Sumatriptan is used whenever prodromal effects of migraines begin to start. As soon as you feel those, it would be Sumatriptan that you would take. It is available in an ODT, which I would once again suggest because she's dealing with nausea and vomiting. I would suggest starting that at 50 mg once daily. It would be 50 to 100 mgs, and you can take it once. And then if you're still feeling that prodromal, if you still feel it coming on, you can repeat it 2 hours later. However, that would maximize the amount you're able to take amount the patient is able to take daily. Some non-pharmacological, like I said, it's with migraine, it's a little bit more difficult. However, if she can avoid just any triggers that she may find, such as like being on a computer screen for a really long time, just prevent those or avoid those triggers that could cause the migraines. For her depression, I think this is very, very important that we treat this because she has a history of depression. Additionally, she has postpartum depression, which can be a little bit scary, especially since subsequent pregnancies upon postpartum depression, they're way more likely to have them, and she's still being medicated for it. She is taking paroxetine, which I would recommend discontinuing that. There's not great evidence with it, and there are side effects and downstream effects that I think that we should avoid. However, I think it's important that we treat her, and with that, I think that I would recommend that we switch her over to sertraline, and we would start that at 50 milligrams once daily. And this is able to be titrated up to a max dose of 200 mg daily. I would suggest a hard stop on the paroxetine and then immediately starting the sertraline just because she is pregnant versus doing kind of a wash in, wash out period with those SSRIs. So I would just go ahead and start that sertraline. Non-pharmacological would really be just making sure you're getting good sleep at night. Follow that good sleep hygiene. Attend support groups if she needs. She's not the only one with postpartum depression. It's very real for many moms. And I feel that getting her a support system, whether that be her family, whether that be support groups, I think it's imperative that we do create an environment that's safe for her to talk about her feelings, what she has going on for both her and the baby. For her levothyroxine, this would be in the management of her hypothyroidism. Now, with levothyroxine, first and foremost, we would definitely want to continue this. There is some literature and guidelines that do say that an increase in dose of her levothyroxine is warranted upon pregnancy, confirmation of pregnancy, which we do have. However, her TSH level right now is within normal limits. It's 1.45. And so with that being said, and because this is more of a stepping stone to get her to her OB, I would draw another TSH level and verify that it is within our normal range, which is below 2.5. If it is out of range, meaning that it's higher, above 2.5, that is when we would need to intervene. But right now, because she's within normal limits, I'm hesitant to increase her dose just because I don't want to create super therapeutic doses in her bloodstream. And for her own personal monitoring with this, it is kind of a touchy area with a narrow therapeutic dosing of levothyroxine. She just wants to look for signs of extreme fatigue, weakness, muscle pain, lack of energy, things like that. And if she does feel that way, contact her provider. We can increase her levothyroxine and make sure that she maintains that good quality of life. So for her prenatal and immunizations, I think this is really important for preventative care. For her immunizations, I suggest that she gets her flu, and right now we are in flu season, so making sure that she gets that sooner than later if she hasn't is appropriate. In addition, COVID-19. This is very, very important because there is bad outcomes for those who are pregnant. They are considered immunocompromised. And being able to fight off COVID-19 if she does get infected and isn't vaccinated, the statistics are not good for her in comparison to if she wasn't pregnant. So I would suggest the COVID-19 vaccine, depending on what she would get. It is a series. So depending on which one she decided to go with, and the first one she can get, the better. You would have one at 0, and then 28 to 30 days, I believe, and then 6 months later she would get a booster. Obviously, she'd be later in her pregnancy at that point, so that would be an OBGYN transitions of care management. But I would also suggest her Tdap in her 3rd trimester. Once again, I would expect that to be managed by her OB. Also, avoiding alcohol and tobacco products. Alcohol is a known teratogenic substance. Obviously, she was unaware of this before. However, the best thing that she can do now is, at this point forward, is avoid it. And then also, she isn't currently using tobacco, but just to maintain that abstinence. Prenatal vitamins are really important, just making sure you get that folic acid and iron. That folic acid is really going to help prevent the lack of closing of spinal and such as like spina bifida issues, things like that. That folic acid is really important. And then also iron. She does have a low hemoglobin and hematocrit, and I feel that supplementing it with these prenatal vitamins that do include iron is appropriate. And also just in general, a balanced diet. You want to make sure you get enough vegetables, proteins, and healthy fats. So avoid trans fats, fatty foods, fast foods, things like that. Because also she wants to maintain a healthy weight throughout pregnancy. Also, STI screening I feel is warranted. If she has never gotten HIV testing before, she'll want to get that done, including gonorrhea or chlamydia. Additionally, if she has a history, which I didn't see it, but if she has a history of herpes, genital herpes, that would need to be managed. So I think that STI screening is warranted just so that we can make sure that no harm comes to the baby where preventative measures are available. And for follow-up, given that this is a transitional appointment with her primary care, once again, we just want to make sure that we have that good transition of care to her OB and that she is successful in making that appointment. And if she is having issues, we can advocate on her behalf. And as she'll need to be specialized by that specialized healthcare provider. And monitoring, once again, kind of in a limited window here since she's seeing her OB in 4 weeks, but we're going to want to make sure to look at her TSH levels with that draw, depending on what we need to do with her levothyroxine, blood pressure, and medication monitoring. You know, how is she tolerating her medications? Is she handling them well? Is there any barriers that she's facing to compliance? We just really want to maximize her medications, improve her quality of life, be able to make sure that she's able to support her family through her job. And additionally, she the vibe that I was getting from the EMR is that this is a very difficult time for her. And I think that we need to make sure that she feels supported and through this pregnancy if she chooses to keep it, but that there are multiple options available for her to look at. So with that being said, her updated medication list, given my recommendations, would be levothyroxine 125 micrograms by mouth once daily. This should obviously be taken without food, full glass of water, typically in the morning is best. Acetaminophen, which is an OTC medication, 325 to 500 every 4 to 6 hours with a max dose of 4 grams. And if she is approaching that higher dose, to contact her provider to see if maybe we need to go with Sumatriptan. Sertraline, 50 milligrams by mouth once daily. Doxylamine, which is over the counter, 25 mg by mouth as needed with that max dose in 24 hours. And then an OTC prenatal vitamin, we just want to boost that iron, make sure she's getting her folic acid. And then, of course, her vaccines to make sure that all of her preventative care is taken care of. If you have any questions, feel free to give me a call. I'd love to elaborate on any of these points. Let me know. I'm with Internal Medicine Pharmacy. Thanks.